Hey y'all, I'm Laura Westafer. I'm one of the attending faculty at UMass Baystate, and I have interest in research. I'm an implementation science researcher, and I also podcast over at Foamcast. Today, what I'm going to talk about, though, is something that is sort of a common problem that we face in emergency medicine, and it's the diagnosis of PE in pregnancy. And these patients, it's sort of like a black box when we're thinking about working up or evaluating a patient for pulmonary embolism. And part of this is because we are obsessed in emergency medicine with a few things, almost universally. We're obsessed with outdoor things. Wilderness medicine, obsessed. Everyone is like hiking and kayaking all the time. We're also obsessed with fleece vests. I mean, I think everyone has one. Ketamine, obsessed. We love it. What does it not do? And of course, procedures, specifically laryngoscopy, we love it. There's something else that we are super obsessed about in emergency medicine: pulmonary embolism. And when you take a pregnant patient, someone that is really two patients all in one, when we see that patient, maybe they have some chest pain, maybe they have some shortness of breath, which are also common in pregnancy, we think of PE, it's the first thing in our mind. But it's not just that we're like, oh, this is maybe PE. We see that patient, we see that pregnant belly, and we think PE, 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 PE. It's not the first thing on our differential, it is like our entire differential diagnosis. So when it comes to the pregnant patient with shortness of breath or tachycardia, we are obsessed. And part of this is because pregnancy is high stakes. You have not just one patient, but two, maybe three, maybe four, hopefully not five patients. And we are told, sort of from day one in medical school, that pulmonary embolism is one of the leading causes of maternal death. When you look at the numbers, though, in the United States from 2011 to 2015, there were 249 deaths secondary to pulmonary embolism. That's not a lot considering the number of patients that are pregnant every year in the United States, or the number of people that are just pregnant. And during pregnancy, there were 115 deaths. So 249 total, but actual during pregnancy, not excluding the postpartum phase, 115. That may seem like a lot because we don't want our pregnant patients to die at all. That is really bad news. But when we say it's one of the leading causes of death, you might think like most patients who die in pregnancy die of pulmonary embolism. And this study was 9% of pregnant patients or even postpartum patients who passed away secondary to venous thromboembolism in general. So what I take away from this is PE in pregnancy, yes, it's bad, but PE-related deaths in pregnancy are uncommon. And it actually turns out that PE in pregnancy, we're told it's a risk factor for pulmonary embolism, venous thromboembolism in general. Just being pregnant, the hormones, they all go out of whack. These patients are at very high risk. But PE in pregnancy is actually not all that common either. The prevalence of PE in pregnant patients who are evaluated for PE, so you're working up a patient for possible PE and they're pregnant, the prevalence of PE in those patients is 5 to 6%, which is really not that high. And a lot of people estimate that that target should be much higher. Now, when you look at pregnant patients that are worked up in the United States, that number is actually almost half. So the prevalence of patients that we work up in the United States, the number of those patients that actually go on to be diagnosed with a PE, under 3%. So we work up a ton of patients for PE that are pregnant, lots of risk associated with that, for very little yield. And there are some other problems here. And one of them is that the PE that we diagnose, we pat ourselves on the back, it may not actually be a real pulmonary embolism. They've done studies and had multiple radiologists read the same CT pulmonary angiogram. And what happens is 5 to 26% of those CT scans that are read as positive for PE are actually false positives. Another radiologist, like a thoracic radiologist, goes back and reads that CT scan, and it's motion artifact. It's some other artifact that is not actually a pulmonary embolism. We over-test for PE in pregnant patients. And it's kind of common, right? Like you come into the emergency department, you sporting your, ultrasound of your fetus, and look, you also got your CT scan to go along with that, because we see a pregnant patient in our emergency department for almost any complaint. We're like, gotta be a PE. The other thing that sort of makes us think about this even more in pregnant patients is because we see PE a lot, we're familiar, and we have a lot of guidance for evaluating pulmonary embolism in patients in general. We've got decision tools, we've got ultrasound, we've got CTPA, we've got D-dimer, we've got VQ scans. We sort of have algorithms and we know what to do. When we apply that same sort of thing to the pregnant patients, it's sort of like, meh, I don't know. Everyone has their own individual way of evaluating these patients. You go to one person and they will give you one way that is the right way to evaluate these patients. You go to someone else, not at all. Totally different. Everyone has their own opinions and everyone is always right. I'm going to tell you the right way though. So risk stratification for pulmonary embolism. One of our most beloved tools in emergency medicine, clinical decision tools. And the one that everyone knows is pulmonary embolism rule-out criteria, because you can be like, done with that patient. Can you use PERC in pregnancy? Well, it did include pregnant patients. There were over 200 pregnant patients included when they created PERC. However, when they went back and they were like, well, who does PERC actually miss? Like, who are the patients that are PERC negative but go on to have PEs? Pregnant patients. So not something I really use in the pregnant patient, because again, I don't want to miss PEs that are truly real in pregnant patients, and the literature sort of supports this ain't the tool to use. What about the Wells criteria? Wells, it has some good points. It has some points that frustrate people, like, PE is the most likely diagnosis. Can you use it in pregnant patients? Well, if you're a Wells hater, good news here, they excluded pregnant patients, so not something that you can really use. The D-dimer. Not that the D-dimer is ever controversial at all, not that people have opinions on it. Can you use it in the pregnant patient? The guidelines are all over the place. Some say no, the American Thoracic Society, the American College of Obstetrics and Gynecology. Well, others say yes, sure, do it. The European Society of Cardiology, Working Group for Women's Health, for the Society of Thrombosis and Hemostasis. They say, sure, use it. Now, why are there these diverging opinions, and why, depending on which physician or clinician you talk to, do they have differing opinions? Part of this just comes to like, is it going to actually help you? Because we know that the D-dimer in a normal pregnant patient without any PE, it's going to increase throughout their pregnancy. So if you look, and they've tracked this, the median D-dimer in a normally pregnant patient, the D-dimer concentration over the gestational period, it rises. So by the time that you hit 20 weeks of gestation, you're crossing over that standard D-dimer cutoff. So you can get the D-dimer, but it very well may be elevated, which is why a lot of people have been like, D-dimer in pregnancy, not going to use it, not helpful. It's also led some to be like, well, what about a gestational age-adjusted D-dimer? We use age-adjusted D-dimers in emergency medicine. Our guidelines all support that. What if we calculated the fetal age? Would that work? And in fact, Jeff Klein, who created the pulmonary embolism rule-out criteria, he published several years ago, well, what about in the first trimester using 750, second trimester 1,000, third trimester 1,250? And just note that some assays vary depending on the type of units, so these may need a conversion depending on what your units are. However, this wasn't really based on actual evidence, so I don't think that that's quite prime time, although it's something that people are working on. So the D-dimer is often elevated in pregnancy, particularly second, third trimester. Is it falsely negative in pregnancy? There's been a lot of talk about this in the literature recently because there was this study, the DAPEP study in the United Kingdom, and they said clinical decision rules and the D-dimer should not be used in pregnancy. That was the bottom line conclusion to their study. And this study said that it's basically because you're going to miss PEs in these patients. Several of these patients will go on to have pulmonary emboli and be diagnosed with that. Now, in this study, 80% of them were anticoagulated prior to drawing the D-dimer and anticoagulated with heparin type compounds, which says kind of two things. They're really high risk patients, so they probably do have a PE, and you wouldn't be risk stratifying them with a D-dimer anyways, or maybe you shouldn't be. And then the second is that those compounds can falsely lower your D-dimer. The heparin type compounds can falsely lower it. So if you're giving it to somebody, then in their blood prior to getting the D-dimer, would you expect their blood to be clotty? Probably not. So, the DAPEP study found that higher risk patients, you can get a falsely lower D-dimer. Anticoagulated patients, you can get a falsely lower D-dimer. So my conclusion from this is that yeah, clinical decision tools and D-dimer shouldn't be used in pregnancy if the patient's getting heparin. If you think they're sick enough to get heparin, or they got it for some other reason, don't rely on that D-dimer in that kind of patient. Now, you may be kind of sitting here and be like, you haven't given me one useful thing in this talk. Like, you're telling me things I already know. I don't know how to work up PE in pregnancy. It's frustrating. I'm just going to scan everybody. However, recently we have gotten some evidence, and a lot of this came out in late 2019. And this is that there are actually some risk stratification tools that, when combined with a D-dimer, you can use to evaluate these patients and maybe not have to scan everybody, which is great. The first is the Revised Geneva score and the D-dimer. Now, the Revised Geneva, it's a common one. It's been well validated. It's not one that's commonly used in the United States. And it's because it's a little complicated. There are a lot of different scores. It depends on your heart rate, whether it's less than 75, 75 to 94, or higher, so it may not be useful in all populations. What they found, though, is that when they applied this and coupled it with a D-dimer with just a standard cutoff, they didn't miss any PEs. And they were like looking for PEs out to 3 months later. They did not miss any PEs. Now, when you took the Revised Geneva and D-dimer and you used that algorithm, they also did some DVT ultrasound, they actually avoided CT and VQ scan in 11.6% of patients. And maybe you're like, yeah, 11.6, that's not that many. But if you could take 1 in 10 or more of your pregnant patients that you were about to send to the CT scanner and be like, I don't have to scan you, that's really important, especially if you think to the sort of how nervous that patient may be, thinking like, I have to sign this consent form. What about my unborn child? What about my breast tissue? This can be really important. Years. Years is a clinical decision tool that's sort of more recent. It's been around for a couple years. It's been validated in the United States emergency department setting as well as in Europe for the diagnosis of PE. And basically it's a probability adjusted D-dimer coupled with a sort of a simplified Wells. Is PE your most likely diagnosis? Do you have signs of DVT? Do you have hemoptysis? If you don't have any of those, you get a D-dimer of up to 1,000. Now, if you have none of those, why are you getting a D-dimer to begin with? Maybe that's the question there. If it's positive, then you get that standard cutoff of 500 nanograms per milliliter. So that's years in general. Can you use it in pregnant patients? Well, they've studied this, and the answer is yes. It missed 0.2% of patients. And in fact, that one patient that is counted as a miss, and part of that 0.2% was somebody who had a DVT at 90 days. Now, I don't know about you, but when I see a patient in the emergency department, I do not hand them a guarantee to be risk-free of all medical problems at 90 days. Like, typically, if I'm working them up for PE or DVT, I think that they might have some sort of hypercoagulability, and I can't guarantee that they're not going to have an event later on. So this is an ultra-conservative outcome, and Years performed extraordinarily well in these patients. It appeared very safe. So Years in pregnant patients, it seems safe. It also prevented imaging in a ton of these patients. Looking at this, 65% of first trimester patients didn't need imaging. You have 3 patients, pregnant, short of breath, maybe a little bit of chest pain, but walking upstairs, it's kind of hard when you're super pregnant, or even just early pregnancy. 2 out of 3 of those, you would not have to image. That's incredible. Second trimester, it's half. It's about 46%, just under half of patients you wouldn't have to image. Still pretty good. Third trimester, you still got to image a lot of those patients the way that we're currently evaluating patients with potential PE in pregnancy. But almost 1 in 3 of those patients that you have in front of you, you can get undergoing imaging, which is not only time spent in the emergency department, length of stay, resources, cost, but also just the fear and anxiety that is accompanied with radiation in a pregnant patient. So Years prevented imaging in 1 in 5 pregnant patients overall, which is really good, looks very promising. Again, noting the prior disclaimers with using D-dimer in patients that are sick enough to be anticoagulated or undergoing anticoagulation for something else. So maybe not in those patients. Years in pregnancy, it's also been endorsed by the European Society of Cardiology guidelines, which are the only ones that have been really updated since these studies were published. So clinical decision tools, D-dimer, they look pretty good. But I'm still telling you, you're going to have to image patients. So what are you going to do there? Because even when it comes down to imaging, there's disagreement over what kind of imaging do we get for these patients. You send them the CT scanner. I mean, what can the CT scanner not do? Donut of truth. DVT ultrasound. What about that? A lot of people want to start there. So DVT ultrasound, it's kind of low yield. About 2% of all comers with possible PE in pregnancy are diagnosed with a DVT if they're ultrasounded, 7% of those with signs of DVT. So you're gonna do a lot of DVT ultrasounds that are gonna be negative. But it's also like really low risk. There's not a lot of risk associated with ultrasound other than the time to do it and the resource utilization. So maybe DVT. But it's not as easy as just getting a CT because it's CT, and some people are like, nope, ventilation perfusion scan, the yield VQ scan, which we stopped doing years ago because the output was low, intermediate, or high probability of PE, not like diagnosis of pulmonary embolism at this branch. We want concrete diagnoses. We want very finite, very certain diagnoses, and VQ scan didn't deliver that. However, in pregnancy, it's sort of a different beast because we're worried about radiation more than ever in these patients, like even more than just kids, because kids are only one person. Pregnancy, you've got multiple. Where is the radiation breakdown in here? Well, the mean maternal dose of radiation between CT and VQ scan, the estimates vary widely. And a lot of that depends on which type of scan or what type of study exactly they're doing. So there's a lot of variation here, but it's not insanely different from one to the other. They're in the same order of magnitude. But what about the fetus? What about the fetal dose? They're really sensitive tissue as well. Again, not a lot of radiation, whichever way you split it. We don't like to irradiate, a lot of us don't like to irradiate anybody if we can help it, but especially fetal tissue, we take that very seriously, but it's not a lot of radiation here. So CT, VQ, both are safe for both the mom as well as the fetus. So again, I'm not giving you much helpful information. Either one's fine, except for me, it comes down to this, diagnostic ability. I mentioned this earlier, inconclusive results. I don't like them because I want to tell the patient, I ruled out everything serious, you're gonna be okay, I think at least for the next little bit. Or I like to say, oh, you know what, there are these ground glass opacities that I'm going to clinically correlate with your cough and tell you that maybe you have an atypical virus or inflammation. We like to have something to tell our patients. And there are a lot of inconclusive results, but CT doesn't have a lot of inconclusive results. The studies, again, vary widely because one of the things about getting a ventilation perfusion scan is you gotta get a chest x-ray, it has to look okay in order to do both phases. But we call the CT scan the donut of truth for a reason. And it's because it can tell you all of those things. It can answer the question, does this patient have a pulmonary embolism? It can tell you that. Sometimes it tells you that when it's not. But it can also answer other things in these pregnant and postpartum patients. Do they have an amniotic fluid embolism, which is a real and serious thing and can very much mimic pulmonary embolism? Do they have some sort of effusion for some reason? Do they have a pneumonia that you just can't see on your chest x-rays, maybe presenting atypically? CTA has better diagnostic ability if you look across the spectrum of disease rather than just focus on that pulmonary embolism, and rather than committing somebody to a course of anticoagulation for intermediate probability PE, which is sort of how I interpret that diagnosis as meh, you can tell them whether or not they do in fact have a pulmonary embolism at this time. So in conclusion, PE, it is not that common in pregnancy. It's still something to watch out for, but our obsession with it in these patients, probably a little bit overblown. Years algorithm in pregnancy, it looks really good. I'd like to see a lot more validation in these patients. A couple of studies have looked back retrospectively. The revised Geneva study did that, and it performed well in that patient population as well. You just gotta make sure when you're using that D-dimer that it's not in patients that are already on anticoagulation or are sick enough that you're like, I'm gonna start this patient on heparin. DVT ultrasound is fine. If you're using the years algorithm, they have signs and symptoms, do the DVT ultrasound. It's probably going to be negative, but that's okay. There's almost very little downside to doing it. VQ, CTA, either one is safe. Both are fine, but I really do believe that CTA is gonna give you more answers. So this is one of the ways that I sort of approach these patients. I have to think, okay, does this pregnant patient, do I really think that they have a PE, or is there something else going on rather than just putting everyone down this pathway? Then I apply years. Is PE my most likely diagnosis, or is it something that I feel obligated to evaluate? Signs of DVT, do they have hemoptysis? And then I put them through years. I ultrasound them if they have signs of DVT, and then if their D-dimer is greater than 1, I scan them if their year's negative. If their D-dimer is greater than 0.5, I scan them as well. So this is what my evaluation, my personal evaluation for pulmonary embolism looks like, knowing that there are caveats depending on whether that patient is super high risk. But if they're really high risk, they're really sick, they don't even fall down this algorithm, and we all sort of know that. It involves clinical gestalt. So in summary, the evaluation of the pregnant patient, it can seem like a black box where you don't know exactly what to do because everyone has divergent opinions, but looking at the best available evidence that we have to date, there is sort of a relatively reasonable and evidence-based algorithm that we can apply to these patients to evaluate them in not only a safe manner that protects them by identifying what's going on with them and evaluating for PE, but also limiting harms associated with radiation. Thanks, y'all.
Thank you, Dr. Westafer. Would you mind answering just one quick question? It's not entirely related to in pregnancy, but it had to do with the anticoagulation and the interpretation of the D-dimer. Do other medications, the 10A inhibitors, good old-fashioned warfarin, do they also, should we have less faith in our D-dimer in those patients as well who are taking those medications?
That is a controversial question. Definitely those that are on heparin, enoxaparin, those types of medication, the D-dimer is not reliable in those patients. So if you have a patient who is giving themselves home enoxaparin injections post-operatively or because they have a history of PE, in those patients, definitely not. It is thought that the novel sort of target-specific or direct oral anticoagulants, rivaroxaban, apixaban, have not that same effect on the D-dimer, but there's still a lot we're learning on these medications. So it's sort of a case-by-case basis and also figuring out what is it really going to change if a patient is already anticoagulated. If they're on an oral anticoagulant, you might bump them up to enoxaparin. If not, it might not change anything if they're already on a heparin-based agent.
Thank you very much.